Okay, so we're gonna dive into chapter 2. This is all, again, kind of foundational things that we need to know to get into this line of work. So, the first 4 or 5 chapters are pretty dry, but we'll probably get into chapter 3 tonight, and that's gonna kind of dive into a lot of concerns that people have as EMS providers, with like, am I gonna get sued, kind of stuff. And then we start moving into like the documentation, communications, and we're gonna scratch the surface on that because the documentation that's required of an EMR is a lot less than an EMT, but we're gonna start building those EMT foundations if and when you choose to go on, and especially now, I don't know, like if Lac de Flambeau's operational plan allows for EMRs to be part of a legal ambulance crew?
You can drive.
They can drive?
Yeah.
Okay.
Basically,
So, I mean, technically, it could be an EMR and an EMT. Because the state allows some exemptions, and we talked about that last week, that, for the most part, to be a legal ambulance crew, you have to have a minimum 2 EMT basics, with exceptions of, I think most of the communities up here are small enough that they will allow an EMR to be part of that, that crew in lieu of 2 EMTs, So, I'm kind of balancing that. We want to teach you what you need to know to become an EMR, but we also want to set up you and your community to succeed as well. So I'm kind of trying to do both, but I'll be clear to differentiate the difference between the two. But, okay. Safety and wellness. And I kind of skip a lot of these case studies because they have to do with transport, but we're going to dive right into the fun topic. Emotional aspects of emergency care. So what I want to say is we're entering a line of work, and please, I'm not doing this to create fear, but we want to talk about these things because they're real, and you are going to see it if you are responding to emergencies. Even if you're not on a department and you're in this class because, what if I drive up on something or someone collapses in front of me? I just want to be better prepared. All those incidents, you're going to be dealing with emotion, and pretty strong emotion. So if you think, and you don't have to raise your hand, but you think about it, if you've had to call 911 or you've had a death in the family, just on a personal level, think about the emotions that hit you, that hit the people around you. It can be, and emotions are subjective based on the person. And I'll give you a personal example. My child gets sick with something, and I should say adult child. That to them, this is the worst thing, and that they probably need to go to the emergency room and get emergency treatment. Me as a 30-year paramedic, look at them and say, you're fine, rub some dirt on it. So what they see as a true emergency, I may look at like it's really minor. Okay, so emotions are different based on the person. Anytime we're doing medical work, you're gonna run into cases where people have either already died, and we really have 2 options. If they're dead, clinically dead, no pulse, not breathing, do we intervene? Sometimes we don't intervene, and we'll dive into that probably today too. But the person who's deceased, somebody found them, somebody activated 911. So we're walking in and it's usually a friend, family member, spouse, and the emotions are extremely hot. And I'll even throw this at you, what if it's a kid? So when we deal with pediatrics, and this is why whenever you talk to any EMS provider, pediatrics is tough for a lot of reasons. Number one, we don't do it very often. So kids are pretty resilient. Usually we get ambulance calls for kids. Majority of the time it's minor. But every now and then we get one where they're critical to include death. So if you can imagine the charged emotional atmosphere of a pediatric injury or death, it's tough. And not only are we dealing with our own emotions, we're dealing with the emotions of everybody that's around them and the whole scene. The 5 stages of death, I'm sure everyone's heard about this, that some psychologists said that everybody goes through these 5 phases. And, you know, I've seen varying levels of this, and I can also come in from the perspective that for about 15 years down in Wood County, I was a death investigator. Coroner, became chief deputy coroner. This was a side business, so I dealt with death all the time. The difference was being a paramedic, there was what we call hope. So when someone calls 911, everyone's hoping that the ambulance is here, they're gonna save it. When I come as a coroner, hope is gone. It's death. So I've seen many of these different stages, not only as a 911 provider, but as a death investigator as well. Denial, we see that a lot on first notification, no. Anger, we tend to step into a scene at this stage, and they're angry, and they don't know who they're angry at. The situation is out of their control. And a lot of time, us as EMS providers become the target of the anger. Why did it take you so long to get here? You guys aren't moving fast enough. Just take them to the hospital. A, B, C, D. And, you know, I can argue statistics with them till I'm blue in the face, but that's not the time and place. No one here has probably ever heard of Dr. Antebi. Dr. Antebi is a pediatric emergency room physician around the Orlando area, somewhere down in Florida. So the hospital is busy enough that they have an ER physician and they have a pediatric. His only job is to take care of kids. He's developed intense training, big into research. He's what I would call one of the modern day leaders for EMS systems. Dr. Antebi, when he first took his job down around Florida, what do you think they have a lot of in Florida? What's in everybody's backyard? Swimming pool. And so they saw a ton of pediatric drownings, tons of them. And what they found is that survival rates, after 20 years of data, hadn't changed. And single-digit percentage of a drowning being successfully resuscitated. And the policy was, and even when I started, when you get a sick kid, we throw them in the ambulance and go as fast as we can to the hospital. We provide very limited treatment. And for those that have not been in the back of an ambulance, it's hard to do treatment while you're driving down the road. It's difficult. So we can't do the skills as we would. Now, if we compare that to a 70-year-old that collapses at the grocery store, what do? We work them. We work them right there. Chest compressions, breathing tubes, IVs, meds, we do everything right there. But with a kid, we throw them in the back of the ambulance, just drive as fast as we can. So Dr. Antebi initiated with 3 of the big fire departments down there that I want you guys to stay and work on the kid just like it's a 78-year-old person. Do all the treatments that you would do for everybody. And they found a 10-fold increase in outcomes by staying and working. Basically, this study was black and white, overwhelming data. If you stay and work the resuscitation of a kid just like you would an adult, they've got a 70% chance, better likelihood of being resuscitated with a successful outcome. But we show up in the ambulance and we start working on a kid right there. What do you think the parents are? And think about those of you that have kids. Get going to the hospital. It's tough, and we can't explain to the parents at that point that, well, Dr. Antebi did this research. You know, they're not going to listen. So, I guess what I'm trying to get is just kind of prep you for those stages that we're going to run into. I guess just kind of going in, you know, anger is pretty self-explanatory, but bargaining as well. You know, we've seen this a lot, and I know this is kind of referring to what it is, a paramedic. Well, we would work with cardiac arrest, and we're doing pretty much all the standard treatment that they can do in emergency. All the medications, tubes, IVs. And we would work a cardiac arrest for an average 30 minutes. And then at that point, you can kind of tell with our diagnostics that the heart's just not responding. And at which point we would terminate. We just say, we're going to stop resuscitation, and we're communicating with the family through this, and we'll kind of talk about ways to do that. But tell the family, hey, we talked to the doctor in the ER, and then at this time, we're going to stop. We're going to stop resuscitation, and the physician, we're going to pronounce Mr. Smith dead. Bargaining is where we start to see, well, what if you guys just tried this, or have you tried this? You know, they start to, you know, what if we did something different? We see a lot of bargaining. I saw this at this corner of a lot of survivors. Well, you know, what if I would have done this, or would have, right? And, you know, that's, a lot of times we can't give the answer for it. Depression, usually I've never seen this so much when we're there, because we're kind of in those first hour or so. And it takes time, and sometimes people just never get to the point of acceptance. So, dealing with the dying patient, family members, now, dead or dying. In the event you get on a system where you're going to respond to 911 calls, we're going to get calls to people who are terminal. And has anyone ever heard of like hospice care? Okay, so hospice, palliative care, that they're all kind of grouped into where a patient, their physician, has decided that medical intervention, intensive medical intervention at this point isn't going to make a difference in their outcome. So there's nothing we can do to make them better. There's things like the organic brain diseases, like some of your Alzheimer dementia, Lewy body dementia, that you can't fix. That right now, science, there's nothing we can do for it. And they will just progressively deteriorate until they succumb to that disease. And they've decided at this point, nothing we're going to do is going to make them better. We move them to hospice care where it's more, we want to try to make them comfortable. And a lot of people rightfully want to die in their home. And some of those people, well, I should say the majority of them, will enact what's called a do not resuscitate order. Meaning that in the event my heart stops beating, I don't want CPR, I don't want breathing tubes, just comfort measures. Now, if they break their arm, we can treat them for pain and make them splint their arm, take them to the hospital. We're just not doing resuscitation. Family understands that, patient understands that until it happens. So there are a lot of times that I've been activated, we show up and the family will do something, and they have a valid do not resuscitate order. And some people are prepared for those times, some people aren't, but we have to intervene, and we always have to advocate for the patient. I'm kind of starting because I don't want to jump ahead too much or get into things that you guys don't really need to know at this point.
I have a question. How would you know if they have a do not resuscitate order?
Excellent question. So through this training, in fact, especially when we do medical legal, is we ask. Do they, especially if someone's to the point where they're either in arrest or what we call peri-arrest, and arrest means their heart's about to stop. So peri-arrest means it's about to stop, arrest means it did stop. Both of which require pretty intense resuscitation. So if we're to that point, and for the most part, if people call 911, we see someone collapse at a grocery store, restaurant, out in public, or suddenly in their home, and they appear well. Honestly, rarely do I ask unless I find identification. However, when I go into a home and there's a hospital bed in the living room, or I look at the patient and they're emaciated, you know, you can tell undernutrition, not from abuse, but just because their body's not processing proteins anymore. You can see it. This person's kind of terminal, and we'll ask, is there what's the resuscitation status? Do they have a DNR? And up here in the district, we don't have long-term care facilities. Now, does Lac de Flambeau have any? Okay, so you're going to run into this in long-term care facilities. Do you guys ever get ambulance calls there? And it's one of the reasons that drew me up here for a job, because we don't have long-term care facilities. And if I can, I'm going to go on a brief tangent about that. So long-term care facilities, there's a bunch of different ones. CBRFs are the most common. CBRF stands for Community-Based Residential Facility. You're seeing it a lot where they'll buy a 4-bedroom home and take like 6 people. There's state money, there's money to be made. The requirements for medical training of staff is super small. You go up to assisted living where it's generally a group of seniors in one building and they may have, you know, a person there preparing meals or a manager to kind of oversee their daily needs, up to a skilled nursing facility, which is a medical institution, and that generally has at minimum a registered nurse on staff to provide medications and treatment. All these facilities, senior care, special needs care, there's going to be an increased likelihood that they need medical assistance through the 911 system. It used to frustrate me because we would seem to get called for every minor thing where if the complaints were one of us, we'd probably just take an ibuprofen and some rest. But these facilities, they got rules and regulations because they're fear of lawsuits, so anytime someone has a complaint, just call 911, take them to the Through working with them as long as I did, unfortunately, a lot of these facilities, and at no fault of the staff, they're understaffed for the most part, that they have one caretaker trying to take care of more than 5-6 people. And if anyone's ever had to take care of an elderly or someone kind of meeting their end of their life, just for them to go pee can be a 30-minute process of getting from the chair to the bathroom, clean them up, get them back in the chair. Now, if you're in a facility with 12, 16, maybe 50 residents, and they all gotta go pee at the same time, so they're horribly understaffed. The training they give them is subpar as far as responding. They're really good at hygiene and how to wash and how to change beds, but they don't do a lot of medical training for them. I mean, you think this is 108 hours. So in a lot of care facility staff, it's usually a couple nights at a tech school to get your CNA or things like that. So they're understaffed, they're undertrained, and they activate us a lot. And they don't, a lot of times when we go there, the administrative person whose salary 40 hours a week is gone home, and so the staff doesn't know where the do not resuscitate paperwork is, the files, and if they do know the file, they don't know where to look in the file because each person has a folder that thick, and it's somewhere buried in the middle as far as the resuscitation status. So when you call, the person's in the process of dying, and what's their resuscitation status? Nobody knows. So we always err on the side of resuscitate if we don't. But the kind of problem is that I kind of go off on tangents sometimes. The state of Wisconsin DNR, and there's clear statute regarding it, but you can have a identification of can look like a hospital band, or there's medical bracelets. If anyone's seen like medical alert bracelets or necklaces, there's a bracelet or a necklace that they can take. It's very specific. You can get them from one vendor. Has to have state of Wisconsin on it, and do not resuscitate. And the reason that is because you could probably go on Amazon, buy just a generic DNR, put it on grandma who's got a lot of money, that's very much on state of Wisconsin. Do I think people do that? No. But it's, and there should be paperwork that accompanies it. So if we find someone unconscious, and we probably can run into it up here, people come up to the cabin, their DNR, and they're trying to get one more getaway and find them slumped over in a chair. And we'll learn about an assessment where we go head to toe on these people. And if we find that medical ID bracelet, we honor it. Now, would you be legally culpable if you ever did do CPR and then found out they were a DNR? No. In fact, over my career, I have successfully resuscitated over 50 do not resuscitate patients. And we didn't find out till we got to the hospital. At which we did all this work, got a pulse back, blood pressure. The doc looks at the paper, says, oh, they're DNR, pull the tube, let them die. It happens. But this line of work, high stress, so the good news is, being an EMR, is you're we're a pretty low acuity system up in the north. Even I'll say Minneapolis, it's pretty low acuity when you look at compared to a lot of the other systems. But if you're doing this for a living, it is long hours. Adam, how long you working?
48.
48 hours. 48 hours he's here. So you gotta remember, I'm not paying him for what he's doing. I'm paying him for his time away from his wife and kids. So, a lot of people work 8, 12, 15 hours, but imagine 48 hours. And that's pretty typical in career EMS systems that work 24, 48 hour. Some of your busier systems, maybe 12-hour shifts, but you are running call to call to call to call. You don't see the station, ever. You're eating lunch out of the ambulance. Boredom between calls, we can run into that up here. In fact, I would say in my career when I was a firefighter paramedic, the stress wasn't the high critical calls, right? And just, who's on a volunteer fire department right now? Okay, so let me throw this out to you. 2 o'clock in the morning, call comes in for a 7-year-old male has fallen, he's uninjured, needs help getting up, bring extra lifting assistance, which is code for they're heavy. All right, so tonight, windy, cold, what's your turnout gonna be? Okay, so we're laughing. Now, let me say, at the same time, 2 o'clock in the morning, tones drop. We have a 2-vehicle rollover with 2 ejections over at least 4 patients. 2 of them unconscious. What's your turnout gonna be for that? Everybody's coming, right? Because, you know, the mundane, the low, boring stuff, and I'm just gonna call it what it is, everyone's like, ah. You know, but if it's exciting, and we get to use some skills, so for me, a lot of my stress was the just mundane of the UTIs, and the lift assist, and the non-emergent type calls, where, you know, we were trained as, I was a career firefighter paramedic, I wanna go on paramedic calls, I wanna go on fires, not the bull crap. So that can be a lot of stress, just as much as working critical patients. Work too much, too hard, volunteers, you know, how much time do you guys put in it that you don't get paid for? Okay, ask an accountant to do stuff on their day off for free. Or ask an HVAC guy to come over and fix your furnace for free. Let me know how that works for you. Getting a little recognition, welcome to EMS. You know, the one thing, people up here tend to be more appreciative, but you get in cities, it's very easy to get, I always say if I didn't get peed on, pooped on, or spit on, it was a good day. And having to respond instantly. This isn't the line of work that when the tones drop, you drop what you're doing and go. I mean, I don't have time to, well, let me go do my hair quick, which this is part of the reason why I shave it. I don't have to worry about it. But that all adds to stress. Making life-threatening decisions. I'm gonna throw this out. You pull up to a house, just, someone injured themselves with a saw, and they ran a skill saw across their thigh, and blood's pouring. What do? Person's pale, sweaty, screaming. You show up with your little bag. We gotta stop the bleeding, right? So, one of the things we do is a tourniquet. And how many of you have been told that if we put a tourniquet on, the arm or leg is coming out? Okay. Well, I'm gonna tell you now, that is the first thing we do, is we just throw the tourniquet on. And here's the science behind it. We tighten it until the bleeding stops. That's it. Just like shutting the faucet off. Put a band on and tighten it down. But, a lot of people, you know, we're making this decision, oh my God, it's here, am I actually gonna put a tourniquet on? Is this the right thing to do? That adds to stress. Fear of errors, you know, what if I put this tourniquet on and it wasn't supposed to be on? Well, what I'm gonna tell you is the skills and what we give you in this class, we're gonna give you the comfort margin of error. So I can tell you, if you're looking at someone bleeding and you think it's bad enough to put a tourniquet on, it's probably justified. And if we get to the hospital and they find out, we could have just stapled this, really didn't need a tourniquet, It's not the end of the world. They're gonna keep their, unless there's devastating injury underneath the wound, 9 times out of 10, they'll keep their extremity. In fact, has anyone ever had a knee, any surgery to an arm or leg? Because if you've had surgery to your arms or legs or knees, they put a tourniquet on you for about 3 hours in the middle. Because they don't want to be operating with blood pouring out, so they just put a tourniquet on. And you still got your arm or leg, right? Or no feet. So, being responsible for someone's life. I'm going to repeat this a couple times throughout the class. And it used to really stress me out that I felt I had this ultimate responsibility that almost like it's my fault that they're hurt or sick or whatever. When you're in this line of work, when them tones drop, it's not your fault. You didn't cause the whatever's going on. You didn't cause the injury. You didn't cause the illness. We are there to help. And that sometimes we can do everything perfect and the person will still deteriorate and die. Okay, so being responsible, we are responsible to ourselves for being professional and maintaining our skill set, maintaining our knowledge, keeping up, making sure our equipment's ready. That's what we're responsible for. So if you show up, you've got the training, your equipment's ready, your mind is ready, that's what you're supposed to do. You're not responsible for what happens to the patient. This stuff is pretty self-explanatory, and we'll touch on it, but I'm going to give you the real perspective of levels of stress on the EMT. You know, multiple casualty incidents, you're going to hear me refer to them as MCIs. How many patients do you think, if we had a car accident out there, how many people do you think we need to have in that car accident to trigger an MCI? That's it, 1 or 2. You know, I was in Rapids, you know, we had a little bit more staff, so 5. But, yeah, 2 patients. It doesn't take much to create an MCI up here. It's whenever the patients outnumber your available resources. Abuse, neglect of kids, elderly, basically the people that can't stand up and protect themselves. I want to say it's a lower likelihood up here in the Northwoods, but you very well may see it. Anything with kids. Death of a coworker, death of a friend, and we're up here, you're responding in your community. So there's a good chance that you may get a call for someone that you know. And then severe trauma. Anybody, and you don't have to raise your hand, I alluded to this the first night. Trauma, looking at people who are hurt really bad, it's not fun. In fact, I would be concerned of the person that likes looking at that stuff. I still, after 30 years, walk into someone with a broken leg or even a broken clavicle, and inside I'm going, that's gotta hurt. But we just get to work. You know, there's things we gotta do, so we're working on it. But, you know, seeing that stuff can produce stress. I'm gonna get personal. For me, in my career, here's what caused me stress. Missing my kids' functions because I was at work, or getting called away. So I'd be at one of my daughter's dance recitals, and you know the phone rings. We got a working fire brigade. Everyone come in. So it was the stress of leaving it, but there was the stress of, okay, my wife's going to be mad at me for the next week, so life's going to suck. And about the time it would get better, it would happen again and again and again. Seeing your coworkers, responders on your department going through tough times. If you're struggling at home and you still got to go on a call, you can't, it's hard to separate the two. Or you come home from a bad shift or a bad call and your family's there and they're not completely understanding of what it is, what you do. That's the stuff that adds stress, okay? So, you know, the responding to calls, that's what we're here to do. It's the things that they don't talk about. Different stress reactions, acute, delayed, and cumulative. Acute is obviously pretty self-explanatory, and sometimes stress is a good thing. Stress allows us to focus, it activates our fight or flight response. It allows us to almost be super performers. It's a force multiplier when we have to exert ourselves physically. So I can tell you, every time I walk into a room and the patient's critical, I have an acute stress response. I've learned how to kind of manage it, but when I walk in and see someone and they are struggling to breathe and they're looking off into the corner of the room, they're not interacting with me, that tells me we got about 2 minutes and this person's heart is going to stop beating. And I got about 5 minutes worth of work to do before I can actually start treating the problem. So I know that person's probably going to go into cardiac arrest. That's acute stress, and that's going to happen on call. Delayed stress, that's obviously just what it says, delayed, may come a day, a week, months later. Then you get cumulative stress, where it's maybe not one big call, but it's, I just responded to 30 system abuse calls where, how can I put it in perspective? Again, I haven't seen it up here yet, but in EMS, can you imagine, middle of the night like this, it's cold, you gotta get dressed, drive to a house for a 40-year-old man that fell on the floor, needs help getting up, and you walk in the house, and there's 6 adults playing video games, and they just point. Pick them up. We don't have to pay for it, and that's what we pay you guys. Now, you go on 15 of those calls, and back to back to back to back to back, that builds stress, things like that. Stress reactions, we're watching for ourselves, we're watching for coworkers. One of our paramedics, Katie, she specializes in this, and one of these nights she's working, I'm gonna have her give her a little 15-minute presentation on it. But she's really dove into like the incident stress debriefing and things like that, recognizing. But usually what I've seen with coworkers is, they start to get angry when they shouldn't be, short-tempered, start to get complacent in their skills, start to lose interest in things that they used to like. So they used to go skiing all the time, and now they're selling their skis. These are all big warnings, and we need to have open, honest discussions with them. Sometimes we can help, sometimes we need to find someone that can help. How do we manage stress? The book's gonna give you the same bull crap. Eat healthy, start working out, which is, hey, if that's your thing, and I tell you, I notice a difference. If I got a long week and I'm eating like crap, I feel like crap. I don't know, does anybody feel good the next day if they, where's the youngins? You guys better not know the answer to this. Let's say you go tip a couple too many the night before, how focused are you the next day, right? So eating healthy, avoiding self-medication through alcohol. Now, I'm not saying don't drink, right? Clinically, alcohol is a poison. That honestly, if alcohol came out today, it would be Schedule 1 illegal. The data is out there. But you're also talking to a guy who likes a good cocktail once in a while. Everything's in moderation. But if you feel the need to medicate with unhealthy behaviors, it's time to talk to someone. And just know up here, so long as I'm alive, I am always available to talk. It even is my goal, it's the other thing with my property into retirement. We plan to be a respite for first responders, and that's one thing that we're working towards. It doesn't, learn to relax, exercise often. I'm a big proponent of exercise. I feel better when I'm exercising. But you've got to find ways to just disconnect from the job once in a while. Keeping balance, and this is probably the most important thing. So if you have a spouse or a significant other, talk to them. Let them know that you're in this class. Talk about them of things we talk about. Let them know ahead of time that, hey, I'm probably going to have some bad calls, and let's talk about it before it happens. That when I come home and I just need 10, 15 minutes, I'm just going to say that. So being open and knowing that relationship with, again, be it spouse, significant other, friends, family, of just talking about it before it happens, so that when it does happen, they know how they can best help it. accept that you're human and mistakes will happen. If anybody, I don't expect you to do it, but the Institute of Medicine released a document, gosh, this was many years ago, called "To Err is Human." And I'll tie that in. Does anyone want to know the number one cause of in-hospital deaths? Medical error. Yeah. Every physician, if they're honest, will probably, at some point in their career, do some treatment that leads or contributes to the death of the person. Not because they meant to, but because of an error. You read about it in the news all the time. And as you increase in specialty level, the room for error increases. We put a lot of engineering controls, training controls in place. On my previous department, I'll use an example. We had 2 vials of medicine that looked very similar. One was Toradol, which is almost like an IV Tylenol. It's an anti-inflammatory pain meds. The other one was Versed, which is a sedative, hypnotic, and can stop you from breathing. Our crew accidentally gave the wrong medication. They gave the Versed instead of giving the Toradol. So what they thought they were treating pain from kidney stone, the person went unconscious and started breathing. Now, they had the training to recognize it, initiated treatment, and were able to reverse it. But that was an error and almost led to a sentinel event. So mistakes happen. The big thing through this class is we're going to try to do enough repetition, enough training to really avoid that. Now, the good news is with the EMR level, there's not a lot within scope that can, so long as we're working within our scope of practice, will lead to death. Like we don't want to do catheter shears, right, Adam? Adam just passed as advanced emergency medical technician. So yeah, just kind of recognizing, watch friends, watch coworkers, buddy system. You know, I had on the department, I had a close friend that I know I could talk to if things are bugging me, and it doesn't have to be a coworker. Whoever you're comfortable talking to can be a pastor, a family friend, a parent, anybody. Just find that person that you're good with talking to. Critical incident stress management, this is something that may occur. So if it's a high profile incident that potentially results in some emotional damage for the responders. Mental first aid, if you will, that they may stand up a CISD or CISM. There's teams that can come in. These are people that have gone through extra training to help those responders, to provide them that mental first aid to keep performing. This is usually coordinated. I don't know what they have. I'm going to ask those at that here. Do they have CISM up here or the ability?
For, like Howard Young's got something.
Howard Young's got a team? Yeah. Okay. I know we are, it's kind of one of my...
We're going to Katie now.
Yeah. Katie's kind of helping get this thing organized. So hopefully we've got a Northwoods CISM response team. It's going to take a little time and it takes a little bit of money too. So, but we are working. But so you get through this class, you're responding to a call, and it's a bad call. Either you talk to someone or you'll be reached out to, hey, this is a bad gig. We're having a briefing 6 p.m. tomorrow night at Boulder Junction Fire Department. Come on now. What the critical incidents management doesn't do is it's not there to blame or, oh, you should have done this. It's mostly, and as someone who's been through them, it's just where everybody has an opportunity to say what they saw, what they felt, what they thought, and everybody has that opportunity to kind of get that out loud. And then there's people who are trained to help kind of navigate you through the next phases, and even recognize that maybe that individual needs to go a little extra step, and we have direction and guidance for them to go that way. What bothers everybody in this room isn't the same. and I'll speak, you know, I worked a lot of cardiac arrest in my career. And, you know, we would go to these people, end of life, I knew we shouldn't be resuscitating them. There's nothing we're gonna do is make a difference. The cardiac arrest didn't bother me. It was the just watching the spouse in a recliner on the opposite side of the room. Not crying, not being hysterical, just a tear running down their face. And you think they've been married for 50, 60 years, and they're watching their spouse die. It's things like that that I would take home, that would bug me. So you talk to the most paramedics, they would say, 82-year-old cardiac arrest, that's bread and butter, it's a Tuesday. But maybe that one. And I was always comfortable enough to talk about it. I'm comfortable enough to talk about it to you guys in here. Any questions on that kind of emotional? So before we dive into the, what time is it? 10:02? All right, let's take a quick 5-minute stretch break. Go to the bathroom if you got to. I want to get a box of gloves out of the supply room.
Size matter.
Okay. All right, so obviously workplace safety, we gotta talk about scene safety. I'm gonna tell you, in EMS, when we're in a pre-hospital environment, technically there's no such thing as a completely safe scene. We are walking into austere environments. Roadways still make me horribly nervous, not because of what's going on in the accident, but other people driving. And think about it, when you've driven past a car accident, what do you tend to do? You're not looking what's in front of you at the fireman waving at you, but, you know, we have to be an advocate for our safety, for our coworkers' safety, for the patient's safety, and the bystander. And that's, you know, when we would teach, it's always make sure you protect yourself, you protect your coworkers, you're protecting the patient, and then you're protecting the bystander. But that is a good point. Never act outside your capacity. So remember, we're EMS. So if someone starts to get violent, we just see, I'll go walk away, let the cops come in, do their thing. And then once that potential threat is taken care of, then we come back in. So protecting yourself against disease. Yes, we will encounter disease in this line of work. Disease comes in many forms. Generally, I describe all these as pathogens. So not all pathogens are bloodborne, some are airborne, and I think everyone's probably got their pathogen course just in the last 5 years with COVID, because everybody became an immunologist that you watch. I will say that, you know, I did this job for a profession for almost 30 years. And, you know, I got sick a lot less than a lot of other people I know, even though I was in a 4x8 box of people for hours at a time. We just follow the steps, and what we can do to best prevent pathogen entry. It's super simple, it doesn't really cost any money, and a lot of it's honestly just common sense. But, we do have to break down kind of each of these pathogens just briefly. But with the pathogen, there's a couple things that have to occur before you get sick. So this even happens with the common cold, also known as a coronavirus. So, you know, the common cold's a virus, and viruses are tough. They're tough to manage, they're tough to treat. Viruses are structurally a little bit different than bacteria and all the other pathogens. Viruses have almost like a force field, if you will, a protective shell around them, where antibiotics don't have that protection. So you can take an antibiotic, which can invade, get in, and kill the bacteria, but as far as antivirals, they really haven't come up with things that can invade the virus to attack the virus. So that's why, like HIV, AIDS, it's a virus, very tough to treat, whereas some bacterial infections much more easier to treat to a certain point. But So there has to be a pathogen present. There has to be a route for the pathogen to enter your body. So that can be, everyone thinks cut, scrapes, open sores. True. Anyone want to take a guess at one of the best entry points for a pathogen? Your eyes. So your tear ducts, going like this, rubbing your tear ducts, that is the best route, because in your tear duct, there's not a lot of barriers to prevent the pathogen from entering your body. Your nose, well, it's got a lot of things. It's got, most people, if I looked in all your noses, yes, girls, you too, it's gonna be hair. So hair helps catch particulates. There's snot, mucus, which traps it, catches it, then you expel it. But your tear ducts don't have a lot of those protective mechanisms. The skin, however, is phenomenal. It is a phenomenal barrier. It's when it's broken and not intact. So you have to have a pathogen, you gotta have a route. You have to have enough pathogen to overcome your immune inflammatory response. So the pathogen has to be able to get into your body, rapidly multiply to the point that it overwhelms the immune response. So every day, everyone in this room is exposed to some pathogen, every day. 99% of the time, your body attacks it, kills it, and you don't get symptoms. It doesn't proliferate, if you will. But that one time, it overwhelms it. And then kind of the fourth thing is what's called virulence. So how much of that pathogen is required to infect you? That would be one way I describe it. So if you took like, I'll just say hepatitis. And again, I could be wrong on this, but you have to be exposed to a pretty decent quantity of hepatitis for it to infect you. Now let's talk about COVID. Now, COVID had a very high virulence. It was a coronavirus and it didn't take much to get you sick. So I kind of use the analogy that if a pathogen was beer, most people, let's just say, and please don't laugh, some people are a little different, but for the most part, 3 beers, you probably shouldn't be driving, right? 3 beers in an hour and you're probably take it easy, take a little break for a bit before you get in the car and drive. COVID would have been like half a beer and you would have been intoxicated. So it didn't take as much. So it was a very low amount of that specific virus to cause the infection. Whereas some other viruses, bacteria, takes a lot more exposure. Bacteria, single-cell organisms usually respond to antibiotic therapy. Now, within the bacteria, there's has anyone ever heard of like gram-positive, gram-negative? So there's, within the bacteria class, it even breaks down into many, many different types. And certain antibiotics work on this one, but they won't work on this one. So it's, when someone has a bacterial infection that they're gonna take antibiotics, is that they will generally start with a broad spectrum antibiotic, which is super generic level that should cover most bacterial infections. What's bad about them is not only are they attacking the bad bacteria, they're attacking the good bacteria as well. In fact, anyone who's on antibiotics knows that you should be supplementing probiotics while you're on, like yogurt. Yogurt is an excellent probiotic. So people on antibiotics get bad guts because it's killing all that gut bacteria, right? They sometimes will culture, so they let it sit in a dish for a few days, look at it under a microscope, and then they can better define what type of bacteria it is and give you a specific antibiotic for that. Unfortunately, also what happens is if we're prescribed an antibiotic for, let's say, 14 days, people start taking it, and there's going to be side effects associated with it. So, you know, I'm running to the toilet every 20 minutes, you know, all this, but, you know, my illness, I want the antibiotics. So you take the antibiotics, and at day 8, your symptoms, I feel fine. I can just stop taking my antibiotics. Problem is now that bacteria recognize that antibiotic, builds up a resistance to it. So the next time you get sick and you take the antibiotic, it doesn't work anymore. That you become resistant. So you, friends, family, anyone you know who's been prescribed an antibiotic, needs to take it for the duration to make sure whatever it is dead and gone. Yeah, so you get, and then when they need to go back in for antibiotics again, they'll prescribe it and that initial antibiotic doesn't work, so now they gotta go the next step up. It's more expensive, you know, as they go up, they always start with kind of the cheap, this should work. And please conduct your own research. There's a lot of people for years, and I've seen it personally, that they just, how can I put, has, and don't raise your hand, but think about if you or someone you know, have you ever been prescribed an antibiotic? And if the answer is yes, did they ever do blood work on you before they gave you the antibiotic? So like, do they know it's bacterial, or do they know it's viral, or are they just giving you an antibiotic to shut you up and get your next patient? So sometimes antibiotics are prescribed for viral or other pathogens that they really don't do anything. Viruses, again, we talked, viruses are just tough. And a lot of times with viral infections is that we can treat the symptoms and we make sure body systems stay effective. I'll throw out RSV. Anyone ever heard of that with kids? We're well into RSV season. So RSV is a viral respiratory infection and it affects kids a lot. We really don't do anything. There's two things that we watch for. We make sure that they maintain good oxygen levels. So some kids can get an infection, get bad enough, it affects the ability for them to carry or to transport oxygen. So we have to give them oxygen via mask, up to severe cases, actually put a breathing tube in, put them on a ventilator. And we make sure that their kidneys are working and they're making urine. That's about all we can do. And there's trigger points to go into the hospital, but a lot of those viral cases, you just give medicine, and they even try, I think they came out now, and pretty much they found that like breathing treatments, albuterol, nebulizer, they don't help. RSV can actually make it worse. So a lot of it's you just, unfortunately, the kiddo's got to go through the virus, and just wait till the body's immune system takes over. Fungi, you know, we don't deal with this much too in the pre-hospital environment, but patients who are, when we talk about immunosuppressed, so this can be through either disease processes, or think about someone who's on cancer treatment, that the treatment they're giving to the cancer suppresses or actually can kill the body's immune system. So what we would normally be able to fight off that pathogen, their body is suppressed either through disease or medication that they don't have the ability to fight that. So, you know, I take a little extra precautions when we are going into a house with someone who's immunosuppressed. You know, and make sure I've got gloves, and, you know, I put a mask on myself, although, you know, the surgical masks don't 100% protect, they do blunt the likelihood of me giving them something. Yeah, protozoa worms, yeah, we usually don't have to get ourselves involved in that with EMS. It's pretty much airborne, bloodborne issues that we deal with, and just protect them. So there's an infected wound. That's a very excellent route of entry. So this is an example. I think it says up there, IV drug user. Guy injected himself. Here's anybody ever managed an overdose yet? Because they do teach Narcan delivery. So the good news is, statistically, opiate toxicity is way, 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 way down. 2015 to about 2023, it was absolutely horrible. But the amount of deaths and overdose toxicity is plummeting. A lot of reasons for that. So that's the good news. But people who inject drugs, anyone ever hear that they like to put it in between their toes? Okay, that's false. 100% false. When people are buying a drug, spending their hard-earned money on a drug to use, that drug is meant to go into a blood vessel. I could poke around a needle for an hour in between your toes and fingers. It wouldn't feel good, but I can tell you I wouldn't find pain. So it's not gonna work. So people, they're gonna use wherever you can find good veins. But yeah, they get, and it's not just IV drug abusers. We can see wounds like this on people who are going in the hospital for treatment or on home health treatment that have, if anyone's ever seen someone they know or a family member that comes home, they got lines, IVs coming out of their skin. That opening, is any opening route in that skin is a route for potential pathogen. So what do we do to protect ourselves? Number one, this is the number one best thing we can do, is after every call, whether we have gloves on or not, is hand washing. And I'm not talking antibacterial soap, just good old fashioned hot soap or hot water and soap. Best thing we can do. Take your gloves off when you're out the call, get to a hospital, get home from your station, just washing your hands. Alcohol-based sanitizers, actually studies have been done, there's really not a big difference between them and non-alcohol-based. So just good old soap and water is probably the best. In fact, antibacterial soaps can actually remove some of the good bacteria on your skin, thus decreasing your ability to fight off those infections. And I don't know, if you've got septics, be careful with your antibacterial soap. So septics, I used to work for Roto-Rooter in high school, and I'm so big on that you want bacteria in your septic. Personal protective equipment, or PPE. You're going to hear this. You're going to get taught when you go into a scenario, is it scene safe? PPE. It's something that's just you're going to be saying in your sleep. And PPE, for the most part, low-level PPE includes eye protection. Because remember, I said the tear ducts are excellent transmission. So if I cough close to you, coughing is airborne. Water droplets, you can't see them. If you get into your tear ducts, you can get an infection. So good eye protection, gloves, and mask are kind of what I call that low level, should be available in every ambulance call. We're going to go through gloves tonight. It's kind of a protective glove. Gowns, masks, we have to carry them in the ambulance. Impervious gowns, rarely. Usually when we see ambulance crews or EMRs putting on protective gowns, it's not necessarily because we're trying to protect from disease, it's just because we don't want to get a person's poop on us. You will see poop in this job. Oh, son of a gun. Masks, and I'll talk briefly about masks. So really there's three masks that you guys would probably have available to you. You should have in your kit. Number one is the surgical mask. This is what we saw everybody wearing during COVID. Surgical mask, it's measured in microns. Certain pathogens are measured in micron size. That surgical mask will prevent some larger particles from getting through. I shouldn't say prevent, slow it down. We have an if I'm treating a cancer patient and they're undergoing treatment, it would be very reasonable for me to wear a mask and to put a mask on the patient. Is it completely protecting them? No. But is it significantly decreasing the likelihood of disease transmission? Yes. Surgical masks are the lowest level. And I always would keep one in my pocket, or yes, I wore a fanny pack on the ambulance, got a lot of stuff in there. But I would have a mask, I walk in, someone's coughing, I immediately throw it on. And I throw one on. Just kind of that level. The next one are your HEPA or N95s. These are much smaller micron and can really prevent against a lot more virus. When we get into these type masks, the HEPA N95s, you need to be fitted for them. So they generally come small, medium, large, that you gotta get fit tested. So you sit down either through they put a hood, something where you gotta fit them and do these different movements while you're breathing to see if you smell or taste anything. And then they say you are a medium size or you are a large size, and that size you have there. So if you have an improperly fitting one, it offers a little bit higher level protection, but to really be covered, you have to be fit tested for them. We do have them available, and that's one thing we'll look at this year is, I don't know, probably everyone has N95 left over from COVID, right? You know, there was a time in early COVID where we had to put our N95s in a bag and mail them to Madison for them to clean them and then ship them back, because we couldn't get them. Now we've got warehouses full of them. I should have bought stock. I will tell you that even in my previous job, I can probably count on one hand I threw an N95. That I actually threw an N95. Take away COVID patients, but so when COVID wasn't here, where we were, wear the mask or lose your job. But once in a while, we would, we'd get days for someone with tuberculosis, then I'd put in an N95. Probably the biggest disease that scared me was meningitis. And meningitis can be bacterial or viral. So, yeah, fun stuff. In your book, I don't need to go over it, but you'll see this, and it kind of reads some of the big ones that we run into. So transmission mode is where it comes from. I'll throw a Hep B and Hep C up there. So generally, if you're going into this in a career, you should get your Hep B vaccinations, which, when you're going into for a career. So hepatitis B, hepatitis in general affects your liver. So the word hepa means liver, not hepa mask, but hepatitis. Hepatitis basically means inflammation of the liver. How do you get Hep B? We would usually be susceptible to Hep B with blood. And hepatitis can live in blood for a long time. So if, let's say I had a bloody nose and I bled on this table, 3 days later, I came and touched it. And if there's hepatitis in it, that pathogen is still active and can still infect me. So good rule is if it's wet, sticky, and you don't have proper PPE, don't touch it. Good? And if you do have to touch it, just make sure you wash your hands real good when you're done. But so transmission mode tells you where you get it from, and you'll see a lot of things are when it's blood, that's what we call blood-borne diseases, that they transmit through blood. Anything that says like respiratory secretions, airborne droplets, those are airborne diseases. So like hepatitis, if I have hepatitis and I cough on you, you're not going to get hepatitis. It's a blood-borne disease. But if I have tuberculosis and I cough on you, I could potentially transmit tuberculosis. Incubation period, this is what incubation period is from the time the pathogen enters your body until you start to develop symptoms. So some things like when we take the flu, generally you become infected, if you will, and for 1 to 3 days you have no idea you're sick. So in that 1 to 3, and this is how diseases with high virulence can spread so fast, because that's 3 days of, if you have a person who's in contact with a bunch of people, hops on an airplane, or like you go to Walmart. So, the whole, and I'm going to knock on COVID a little bit, some of the ideas they came up with. The whole distancing thing. That if I was 4 feet from you, or 6 feet, that didn't change anything. Where you get sick is when 1,000 people open the same door at Walmart every day, and probably without thinking about how many times do people do this throughout the day. That's how you get sick. So a lot of people can get exposed to this and you don't even realize. So you can kind of see, kind of read through it. I'm not going to go through each of them with you. A lot of these things are, there are some kind of tested vaccines like the measles, mumps, rubella that have been very, very good at eliminating the likelihood. Whooping cough, that's very much present. We kind of see that rear its head this time of year, every year. You'll see some warnings or, like usually we see in schools, that a whooping cough epidemic will break. Ebola, some of these highly infectious, contagious diseases, they typically originate from Asia and Africa. And this is one of the things that as we get into patient assessment, we have someone with an illness, it's a very reasonable to ask them if they traveled anywhere within the last 2 weeks. And if they traveled and they're displaying signs and symptoms of illness, it's very reasonable for us to back up into the other room and let EMS know that, hey, we have a potentially highly contagious patient. Zika virus, haven't heard much about that. That was rearing its head, ugly head, a couple of years ago. And the big thing with the Zika didn't immediately cause, there wasn't high mortality with illness, but it did affect infants in gestation. So if a woman was pregnant, that it was pretty alarming evidence that it was harmful to the developing fetus. All right, so we're going to pass out some gloves. I'm always a medium guy, but L does not stand for left, it's large. So just grab 2 gloves, there's not a right or left, and I'm just going to pass them around quick. There's medium, large, extra large. They're not condoms, so you can grab mediums if they fit. And then go ahead and put them on. Because you will get used to wearing gloves. How many, and I just, and please, I want to try to eliminate fear a little bit. And again, I'm not asking you to tell me, but it's, think about the last time you've been to your doctor for a well checkup and they're touching you everywhere. How many times are they wearing gloves? Usually. I don't know, just wash it over. Hand washing is. Some people like gloves a little bit looser. I need my tactile, especially when we're like feeling for veins and starting IVs. I need to be able to, I like my gloves tight. Now, a couple things with gloves. You can double glove. So I used to, when I was working as a first responder, we were going to a car accident. I didn't know if we were going to have 2 or 3 patients. So I would never do more than 2, but I'd put on a pair of gloves and I'd put another pair over the top. So when I was done treating one patient, I took the clothes off. Clean gloves for the next patient. I will tell you, if your hands get sweated up at all, and it doesn't take much. We had a car rollover out there right now. Within 2 minutes, your hands are going to be sweaty. You cannot get these gloves on wet hands. You can't. So once everyone's got them on, we'll go through how to safely take them. Has anyone ever done this before? And if you're ever got gloves on or helping on a scene and you get asked to drive the ambulance, please take them off before you grab the steering wheel. This is something we'll practice. You guys are going to have gloves on a lot. You try, you guys to get sick of wearing it. But I am right hand dominant, so to take my gloves off, I grab the glove without touching my skin and I start to roll the glove up So now I'm basically hanging onto the glove, and then I take my ungloved hand, clean one. I go underneath where it should be clean and pull it up. Pull it up and over. Pull it off, and then you find your partner. So basically, you're just rolling the gloves into each other, so that's kind of how. So just go ahead and practice, and if you didn't get it, you grab another pair and play around a little bit, but by the end of this class, we'll have you guys doing that in about 2 seconds. And, we can bloody them up, but I can tell you, if we really want to test you, maybe we'll do that. We'll come in and we'll just put a little smear of poo-poo on them. People tend to be a lot more careful of poo-poo than they do blood. We do have, anytime you're working around, first off, if you're up here in the Northwoods, if you're on scene helping, you can take your gloves off, shed them in the ambulance, we'll clean them up. We have to use these biohazard bags to put anything that possibly has secretions or body fluids on it. Just like any needle, we have to use a sharps container, which we will be doing blood glucose, so we will be using needles in here and doing injections, so we'll get used to using sharps. And I'm gonna go over exposures in a little bit. If you guys are ever responding and have your own equipment, at least here at Northwoods, and I know Lacta Flambeau, we have cleaning ability, so if any of your equipment gets soiled, just get a hold of me and we'll work with you to get you equipment for proper cleaning and or disposal. Blood pressure cuff, blood pressure cuff, we get a car accident, gets blood on it. We can clean it. You might not have the material, just say, hey, we'll put it in a bag, we'll get it clean and get it back. But don't take bloody stuff home. Cleaning, disinfecting, and sterilizing, these are kind of as you go up in levels. So cleaning is just what it says. It's picking up dust, sweeping the ambulance. Disinfecting is like when we spray equipment with something to remove infection. And sterilization, generally something we don't do pre-hospital, but that's where, like surgical equipment has to get sterilized. It's basically cooked at super high temperatures to kill any pathogen. Most of what we use in EMS is disposable. So we use it, throw it away. We'll learn about things called oral airways. These are, it's basically a plastic tube that we put in the mouth and it helps keep the airway open. So you guys will put them in, not in each other. But that's kind of a one and done. I'm from the era we actually used to clean them with pipe cleaners and put them back in the kit. And soak them in. Yeah. And you know it's in oral airways. Of course, the tax is going to recommend vaccinations. Well, that's a whole debate for another day. And this text did come out in the heart of COVID. That's why you're going to see a lot of references to COVID-19. But viruses mutate, right? And I could talk for 6 hours just on this topic, but viruses change over time, which is why now the COVID variant, and please, any pathogen has an ability to result in someone's death. Any pathogen. Anytime you disrupt the ability of your lungs and your body to properly move oxygen, and your kidneys to properly regulate body functions, can result in death. So I know a lot of, any of these illnesses need to be taken seriously, and someone like me right now, statistically, if I get hit with COVID, it's going to suck for a few days, but I'm probably going to survive. But you take someone who's 90 or immunosuppressed, it could be a different story. So what might not affect us, when we're protecting us, remember we're also protecting the patient. So we want to make sure we've got proper PPE on that not only protects us, but we want to prevent, we might have a pathogen that's in the incubation period, and we don't want to transmit that onto any of our patients. Reporting exposure. So if you're on a department, the department may have policy. Does Winchester have an exposure policy at all?
What?
Like one of your members gets, someone throws up blood in their face. Exposure, significance. Okay. So if you're with us in the Northwoods District, we have a policy. Kind of long story short, if you get exposed, and it's a significant exposure, usually for us when we have significant exposures, it's from needle sticks. That's 9 times out of 10. So we're starting an IV, we go into somebody's blood vessel, we hit a bump in the road, needle comes out, and jabs our hand. So we've got a blood-covered needle that just injects. So we, probably the most efficient route to introduce the pathogen. To give you a level of comfort, I have over 60 needle sticks in my career, and I have not contracted a pathogen from it yet. But we still take precautions. So that's kind of the real extreme. Otherwise, if someone coughs on your face, washing your face when you get down to the call is huge. But if you're concerned about exposure, there is paperwork. Usually if you're associated with the department, they'll have a policy in place that for our staff, it's they go to the hospital, a physician evaluates them, can say, yeah, it's a significant exposure, or no, it's not. And even if the doctor says, you know what, it's not a significant exposure, but our staff still has concern, our staff has the ability to tell the doc, well, I like your opinion, but I still want to move forward with filling out paperwork. And it can include up to where they take your blood, get a baseline, and then you have to follow up with primary care providers. So sometimes what may happen is that we take someone to the hospital and a day or two later they realize that they have meningitis. At which point someone from the hospital calls everybody who had interaction with the patient, says, hey, come on in, we're going to start you on some prophylactic medication. Just because we were in an ambulance or in a room with a patient with an infectious disease doesn't mean we're going to get it, but they want to test you and start you on treatment before. Yeah, I say all this stuff like I'm expecting an exodus of people to walk out the door. But people get sick, we got to deal with it. So let's get away from the patient and the overall scene. We're just talking, I mean, use seatbelts. So, we're actually statistically, when you look at fire and EMS, where a lot of death and injury comes from is in responding to the scene. A lot of car accidents, and you get started in this, and I can still remember one of my first calls shaking so bad I couldn't even hold someone's neck still. I can remember that call like it was yesterday. Guy smoking a cigarette, just got in a car accident, bleeding, I'm shaking. If he had a neck injury, I would have made it worse. So when you start this, and if you get a pager the first time the phone's dropped or the first time you're notified of an emergency, that fight or flight response is going to kick in, and then that's okay. All right, it happened to me, it happens to everybody. But if you're driving to a call, that's where people tend to get the adrenaline gets going. They're not focused on the roads. They might be driving too fast. Today, going to Presque Isle, she was a little greasy. I ran non-emergent, 10 under the speed limit, but some people who are new to the job might tend to push it. I'll keep reinforcing that you don't do anyone any good if you get in a ditch or, God forbid, get into a car accident before you get there. We got to get there to provide help. So drive safer conditions, use your seat belts, and I'm going to say right now, everyone's always got a story that, well, so-and-so was in a car accident. They had their seatbelt on, they would have died. Pardon my language, but bullshit. 30 years I've responded to car accidents, not once have I ever had into a car accident and said, boy, if they had their seatbelt on, they would have died. Jim, you've been a medic for a while. Do you ever see it?
We had one here.
I've seen cars.
But, yeah, that's, I think that and maybe one other one. Like, who knows though if he was belted.
I have seen cars where the roof is pushed underneath the top of it, that like, there's no room in it. And they're seatbelt, and we gotta cut them out, they're stuck, but they can usually walk away. Even being a coroner, what I will tell you is the amount of death and injury I've seen from people not wearing seatbelts, huge. And even any motorcycle riders in here, I just gotta say it for my own conscience, wear your damn helmets. We can fix a lot of broken bones and chest and belly injuries, but if you scramble your brain, you're done. Can't fix that. So I'm a huge, please, 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 even just a skull cap, wear a damn helmet. That's all I gotta say about it. Safe lifting techniques, you know, we're gonna talk about that. Don't try to push yourself. If someone's heavy, we don't wanna risk hurting our back. Picking someone up, we call for help, and they stay where they're at till we got enough people to do it safely. They can't quit sleep, I gotta laugh at that. I mean, most EMS systems, we're getting woke up in the middle of the night. And of course, you know, fitness and nutrition, which I don't know that. Is that it? No. This kind of stuff here, we don't have the tools in EMR to safely mitigate. So when we're looking at rescue ops, this can be someone out on the ice. I'll give you a recent example. We had someone go through the ice, New Year's Eve-ish. I don't have equipment to go on the ice and get him, and if he broke through the ice, I'm probably gonna break through the ice. So we let the fire department, who's got not only the training, but the equipment to effectively get the patient and bring him through. So we let them resources do their job. Hazmat incidents, you know, everyone's, and we have to go over a little hazmat awareness in this class, and everyone's thinking the tanker truck or the railway incident. You know, a hazmat incident can be someone's car, portable meth labs. I mean, hopefully we don't see them up here that much, but we're dealing with them in Rapids quite a bit. Violence and crime scenes. Any scene has a potential to become violent. Remember when I talked about the emotionally charged situation? So where we ran into this probably the most was, you know, we show up for an ambulance call and everyone's been drinking. And, you know, we're trying to treat a person with a relatively minor, non-life-threatening injury. But we're not working fast enough for the drunk friend or family member smells. And they're borderline getting violent, belligerent. Scenes get like that, we just gotta step away, and that's what law enforcement deals with. And of course, biological weapons, mass destruction. I will be sending a link for what WMD training that we have to do in this class. It's online. So we'll just let you go from that. We will go through later in the course, kind of at the end, the guidebook. Pretty much if you see a tanker truck or a semi-truck overturned, we just pull back, let the fire department do their assessment before we go running any helps. What is the big hazmat up here? You guys have a lot of anhydrous or with cranberries or? Down where I come from, it's chlorine and anhydrous ammonia. Those are the big two.
What is LP trucks?
LP.
Probably one of the biggest ones, yeah.
Gas transfer?
So
Gas
diesel
transfer?
trucks?
So more of a flammable fire hazard
Yeah.
than asphyxiant. I'm surprised because we have a lot of cranberries where I came from, down Cranmore, that's central Wisconsin, and anhydrous ammonia was moving through there all the time. And that's, anhydrous ammonia is asphyxiant.
You don't see those trucks really.
Not up here. And I know I haven't seen a chlorine car or a railway or, which I don't miss that either. Pretty much if a truck has something like that, that looks on it, just stay away until the fire department or someone returning. That's the guidebook, and that's where we can reference those placards and try to tell us what it is and how dangerous it is. But again, in an EMR course, we really don't dive deep enough. I mean, hazmat awareness is what, a 40-hour course? Yeah.
40 or 60.
We will not be putting on breathing apparatus in this class or as EMRs. But here's stuff, we gotta work down power lines. This is something that you gotta keep in your mind when you're responding, especially to vehicle accidents, house, anything that's on fire, that fire smoke is horribly toxic, and we'll talk about that, probably in the trauma and or medical unit, with carbon monoxide and cyanide and what it can do to you, but stay out of the smoke, stay upwind, and a lot of it, in fire incidents, we're there to support the firefighters for medical rehab and or any victims that are removed. It's just an extreme example. When we're working on a roadway, we are required by law to have what's called an ANSI vest, or a reflective vest on. Firefighters are kind of an exception if you're in full turnout gear, but like my previous department, our policy was put the vest over the turnout gear. But even EMS, if we're working on a roadway, we have to have that yellow vest on. I kind of touched on that. You may hear, when you're responding, you may get a page for, I'll just use Northwoods 9-1 Winchester EMS, we need you to stage at Old O and W. That's all they tell you. And when they tell you to stage, that means it's something that they're waiting for law enforcement to go to make sure it's safe for us to enter. So we report to that staging location, we stay there until law enforcement says, come on. The only time you get around that is like, has anyone ever heard of like tactical EMS? So TEMS, or tactical EMS, that's where they may take a EMT or paramedic and embed them with the SWAT team. Obviously, your job is to go into the threat environment, but for you guys, no one's gonna ask you to vest up and go into the hot zone. What I will tell you is my time as a TEMS medic in Rapids, working with the SWAT team, like I would be comfortable just going in my underwear. No one's gonna hit it. Those cops do a pretty darn good job. Although a lot of them gotta learn how to shoot a little bit better. But meth labs, and this is a really extreme example, and we saw a couple cases. It was kind of one of those things that gets reported on the news, and then a lot of people see it and be like, oh, hey, that's a good idea, I'm gonna do it too. But these committing suicide in a vehicle by mixing gases. And it could be as simple as, anyone know what happens if you mix ammonia and bleach? We make chlorine, which is an asphyxiant, and it will kill you. So if you just take a tub and take a jug of ammonia and bleach, which you can get at the hardware store, and then breathe it for a little while, you'll die. Okay, that's just kind of principles of what we've already gone over. I'm sorry, I don't want to give you a death by PowerPoint, but I use kind of PowerPoint to make sure that I'm hitting on the important stuff. So, what time is it now? All right. Medical, legal, and ethical. It's a chapter in every license level you gotta go through again, and it's painful, but it's the nature of the work, and hopefully it gives you a little bit of comfort of legal protection that as an EMR you will have. Basically, we're in a line of work where we get called to chaotic, unpredictable scenes where emotions are high and people tend to be always looking to make a buck out of someone's trash. So we get put in risk of, we'll say, legal culpability. Now, unfortunately, at the EMR, as you progress in level, the responsibility gets a little bit more, but there's a lot of protections for especially the EMR level. So we're gonna talk about a couple of terms, and one thing tonight is we're gonna put up the Wisconsin scope of practice. So, scope of practice is generally set by the state agency that says what skills and or medications you can or cannot do. And it's based on your license level. So, obviously, the higher the level you go, the more things that are added within your scope of practice. There is a national scope, which is one thing that Wisconsin is trying to bring in when they're doing things. However, Wisconsin seems to be a little bit different in scope of practice than other states. And I would say Wisconsin is probably more progressive in things that they allow as opposed to other states. So the reason we're teaching the 108-hour course for this group is Wisconsin has added a lot of what was optional skill is now required. So in EMR, I don't know if it's true or not, but like Minnesota may not be able to be allowed to do some of the skills that you will be allowed to do. Every state's a little different, so we're gonna focus on, anyone here working in the UP? Okay, good, it just makes my life a lot easier. Because Michigan's a completely different animal. But Wisconsin, all the states need to make sure they comply with the national standards, and then some states can do a little bit of above and beyond, but at minimum, we comply with the national standards. A lot of the nationals, really what's, the group called the National Registry of Emergency Medical Technicians, or the NREMT, is really what drives a lot of these education standards. Now, in this class, you would have the option of becoming nationally registered as an EMR. So at the EMR level, it's an option, it's not required. When and if you were to take EMT, then national registry is required. So EMT and above, you need national registry to obtain a license through the state. EMR in this class, you only need to pass this class to obtain a license. Okay? But whenever I talk about the NREMT, they're the ones that really kind of set a lot of the legal standards. So as an EMR, another term is duty to act. It's a legal obligation to provide service. It exists when you are on with your service. So how can I explain this? Let's say you are, I'm just going to use Winchester for example. Winchester EMS, the first responder contingent of the fire department, or the EMS portion. Or even, we'll say, before the district Winchester ambulance. Did you have a call roster that people signed up for call? That I will take call from 8 in the morning? No.
No.
So that duty to act was kind of removed in that case. So if you were on an organization that you sign up, that you dedicate that I am on call to respond to emergencies within this time frame, that if a call comes in within that time frame, you have a duty to act. You need to stop what you're doing and go. Whereas where a lot of the EMRs, that most of them up here, and I don't think any of our departments have a call schedule. They try to do their best to make sure somebody's available.
We do in Flammo.
Yeah, okay. So you got to dedicate. So those people that are on that, when they're on that list, they have that duty to act. But if you're on a department up here and you carry a pager or radio that, hey, if you're available, this really doesn't, so it doesn't mean if you're an EMR in Winchester and someone has chest pain, you don't have a duty to act to go. If you go, once you basically answer and start responding to it, now you have a duty to act. So you've got a little leeway on that. EMR, for the most part, would still fall under the Good Samaritan laws. And basically, to summarize the Good Samaritan laws, if you are providing care for someone who is sick or injured to the best of your ability and within your scope of practice, that you will not be held legally culpable for, so long as you don't do anything that's negligent. And we'll kind of talk about that stuff, but you're really covered. And the day a Good Samaritan someone takes legal action on a Good Samaritan is the day people stop showing up for calls. So that's why it's really a good law, and I have not seen any, abuse of it. I think, take for example that, you showed up, someone's choking, and you took a ballpoint pen and tried to put a surgical airway. We're not teaching that in this class. It's not part of your scope of practice. So if you try that, you're negligent working outside your scope of practice. A lot of this doesn't necessarily apply so much here. I believe Wisconsin is a statute of limitations, meaning they can't come back after you from an incident that occurred 10 years ago. But I would say it's probably reasonable to maintain records for at least 7 years in the state. So this is why we do documentation of calls. The times I've been subpoenaed to give testimony in some civil or sometimes criminal case as the paramedic, it's usually 3-4 years after that call. Now, when I was a line medic, I'd run 1,000 calls a year. So I don't remember what I did 4 years ago. So that's why we would do good documentation and patient care reports, so I can look back on that and try to remember. I will tell you that in almost 30 years, I was subpoenaed twice as a paramedic and like 4 times as a coroner. So it's not like it's happening all the time. And other times, it was just to give testimony to support one side or the other. It wasn't that I was being questioned. But if anyone pays attention to the news, EMS is not immune from civil or criminal proceedings. I think, well, let's get some controversy going. George Floyd, paramedic, lost their job. Didn't render, I don't remember the details, didn't render appropriate care. Colorado, I believe it was Aurora, Colorado, two paramedics lost their licenses because the patient died after giving ketamine. And in fact, it went so severe, I believe Colorado removed ketamine from their scope of practice because of what 2 paramedics did. So, I mean, the stuff can get serious. Fortunately, you guys don't get to play with ketamine. Medical direction, legally within the state, and I kind of alluded to this last week, that like us as a service, every service, so Northwoods EMS has a medical director that oversees all our operations. He reads through all our protocols and approves them. Winchester EMS has a medical director, even though, you're, work within Northwoods, you can still have your own separate or the same medical director that oversees. And the medical director is the one that will approve your final license. So they can say yes or no. This class has a medical director. It's the same medical director as our ambulance service, Northwoods, Dr. John Schiller, emergency room physician out of Marshfield, level 2 trauma center. He is going to probably be here on the final day just to kind of observe. Don't be nervous about it. Super cool guy. He knows EMS. So, but just as part of my legal responsibility, my medical director has to observe this class at one point or another. So, for the EMR, that when and if you're working for an agency, you will fall under a medical director's authority. They have the right to remove or instate a license at any time. But it's not something to be afraid of. I love my medical director, and he's very involved. He looks at reports, provides feedback, and that's what you want. Okay, ethics and morals. Anybody know the big difference between these two? Or does it say it up there? Morals are more so individual. So I bet you if it comes to, and I'm just going to use this as an example. I don't need anybody seeing. But if I say the word abortion, I bet you there's pretty difference in morals in this classroom as far as where their morals lie. That's neither right nor wrong. Morals are usually individual. Ethics are generally driven by a profession. So what EMS has ethical guidelines that we should fall in, you know, being professional, advocating for the patient. And so long as we stay within those good ethical boundaries, we're good. Morality, your morality is okay so long as it doesn't compete with the ethics of your profession. So, if I had some belief that we should, that when a heart stops, that's what's supposed to happen, we're not supposed to resuscitate. Well, that obviously goes against the ethics of my profession as a paramedic, so I would need to provide the resuscitation. I can't show up as a paramedic and say, I don't believe in resuscitation, so I'm not gonna do anything. We'll send you a bill. What's your address? That doesn't work there. But EMT Code of Ethics, and this is pretty well published. Advocating for the patient, a lot of what we see here, but you know, it's up to you to maintain skill mastery. So when you become an EMR, this is what we have a refresher for. So I'd probably say pretty good chances that we will teach you childbirth. There's a pretty good chance that in 3 years from now, when it's time to renew your license, you probably have a delivery date, or often enough to be proficient. So we take a refresher to say, hey, we talked about this 3 years ago, let's go over it again, just kind of keep it kind of frosty with your skills. So it's up to you to take ownership. Stay abreast and changes, EMS changes, so what I teach you today, and 2 refreshers from now, they might say, Jason was wrong, you were killing people doing that, we're doing this now. That happens. I can still remember when I took my EMT class, we were taught, I just use this example today, if somebody's having chest pain, we need to put an oxygen mask on them and give them high amounts of oxygen. Because they're probably having a heart attack and their heart needs oxygen. That's what I was taught. And as a paramedic, we're like, no, that can actually make them worse. So things like that have changed. That now we do pulse oximetry and we provide oxygen therapy based on that and some other different assessments. But we go to a lot of, we had a chest pain today. Did we ever put oxygen on them? No, we didn't need it. Yeah. And that massive amounts of oxygen can actually make a heart attack a lot worse. Ethical and moral conflicts. You know, and I'm trying to think of I guess, kind of seeing these. So, we're called to care for the bad guy. We are, by our ethics, we need to provide care. So if somebody did something bad to somebody else, and they're hurt, and they're our patient, we need to still treat them professionally and ethically. Would we, am I saying we're at high risk to see some shooter that just shot up a bunch of people? No, but what if we go through a car accident, and someone who was really influenced hit and killed somebody? And he's okay, but he needs treatment. He's bleeding, he's got maybe a broken arm or something. Can we just say, no, we're not treating? No, we need to get, we don't need to be best friends with him, but he needs to be provided that treatment. But where I would run into it a lot is, like a do not resuscitate patient. So, and I kind of alluded to this before, that we show up to a house, they have a valid DNR, and the family is telling you, do everything. We want them to do CPR, do everything you gotta do. It's like, the patient has a do not resuscitate. So what do we do? You know, that's that moral, ethical, where my profession would say legally, we would be okay to say, no, we're not resuscitating. Morally, families there, worst day of their life, when it comes to it, at least I would err to resuscitate. And this isn't stuff that you guys are faced with on a daily basis. I'm gonna give PowerPoint a break here quick. This is I'm sorry, guys. There. I'm gonna send this form out to you in advance. HIPAA basics for EMS, even though I don't know if we'll cover it tonight, HIPAA is involving privacy. I'll just send it to you to read it at your own leisure. But I wanted to bring up the Wisconsin EMS site. So if you Google Wisconsin EMS, and for those that, well, the link for e-licensing probably took you to it, but this is everything EMS in the state of Wisconsin. It's an excellent resource, and there's a lot of stuff on here that you can be a benefit to you. There's a lot of stuff on here that doesn't really pertain to you. To do your e-licensing portal, so who hasn't done it yet? Okay, so basically, you can either just Google for Wisconsin e-licensing, but this is the system that you need to go in, create an account when it comes time to renew your license, or you need to do a application for everything. It's all done through this portal. You will get a password, username, which for my entire career, I've never had to change the password. So it's a site that kind of put it in once. It's good. And of course, I already did but this is where you would go in, and if you weren't in there, you just click create account, and how long did it take?
10 minutes.
10 minutes. So just make sure you do that. That is the e-licensing, and when it comes time, when we're getting to the end of class and we're ready to license, this is where you will do it. Probably the best resource on here is your A to Z index, which has a lot of, you can look for bloodborne pathogens, any topic that's on there, you can click on it. Take you to the statute for do not resuscitate, but I want to go down to scope of practice. So this document is the hot off the press scope of practice. So some key terms, obviously EMR is what pertains to you guys. If you see an R next to it, that means it's a required skill. Or if you see an R in the box, O means optional. So optional is, we'll train you on it, but your service doesn't have to do it. But your service may choose, no, we're going to do that as a skill. And then it breaks it down into a format like this. So for example, the top one, airway, nasopharyngeal. So this is what we call an airway adjunct. It's a latex or plastic tube about yay long that we put into the nose, and it goes to the back of the airway. You guys know because we get to practice on each other, put them in. But if someone does want to put one in, but you can see for the airway nasopharyngeal, EMR through paramedic, that is a required skill. Every level has to know how to use it. The next one down, airway non-visualized. There's a bunch of different types. Kind of up here, we use what's called the iGel airway. What does lactoplambo use? You guys are not sure? Probably iGel. I'll talk to her. But we'll train on all. But these are airway devices where we blindly put them in somewhere. So the iGel, we pretty much open the mouth, put this thing in, and then we hook a bag up to it, and that's what we breathe the person. So it's kind of a step down from like a breathing tube. But the non-visualized airway is an optional EMR skill. We, in this class, will train you how to place the airway. The good news is, super easy to put it in. But you can see it goes through, so this is everything airway. Bag bell mask required. You guys don't have to do chest needles, but you can kind of see everything on there. It covers all the scopes. So airway oxygenation, cardiovascular skill, Cardiocerebral resuscitation versus cardiopulmonary resuscitation, so CCR versus CPR. One includes breathing for a person, and it's CPR, and CCR is just doing chest immersions. And we'll talk about that when we get to that point. So any heart-related stuff, bleeding, you can see we're required to teach you tourniquets. We're required to teach you direct pressure and pressure points and the other optional stuff. So hemostatic agents, that's where we take bandage that has a special agent impregnated into it, and we pack wounds with it to get it right on that bleeding to stop. And you gotta remember, when we're using skills like that, these are dire situations that it may seem invasive, but if we don't do it, they're going to die. Skills, splinting, and it just kind of goes through the different skills that we do, and then down here, different routes of medication. So the first responder is required to learn auto-injector, the EpiPens. Intranasal, we're required, that's if anyone's seen the Narcan delivery device, and I'll talk about why that's a horrible, ineffective. But the O, intramuscular, so we're gonna teach you that too. That's giving a shot to someone, specific for epinephrine in an allergic reaction. Anyone know what an EpiPen costs? Anywhere between $400 or $600. I think they're trying to lower and cap the cost, but still not cheap. The same medicine, a vial of epinephrine in a syringe, is less than $20. So that's why a lot of services do, because it's just a syringe and a needle versus the EpiPen's got a spring in it. It's manufactured, it costs more money. And it even includes the, I think as you go on, you guys can look up this document if you want, but it's into the different medications. So optional for EMR, meds we're gonna learn, albuterol, antiemetic, which is anti-nausea, alcohol wipes. You know, they are super effective at relieving nausea. I would say probably almost as good as like Zofran sometimes. Aspirin, auto-injectors, epinephrine, glucose, Narcan, oxygen. Yeah, so that kind of just will explain your scope of practice. Trying to think anything else big on this site. Down here at the W, this is the weapons of mass destruction here, that I would send you a link for this, that we're gonna have to work on, if you're not set up to the Train Wisconsin website. I'll send a link out over the next week. You gotta log in, kind of create an account like you did for e-licensing. But, so there's 3 classes that you will do through the Train website. And it's gonna be weapons of mass destruction, and if you haven't, also the ICS 1 and 700 classes. Those are something, I'll just get you the links probably this week, but you just need them done by the end of the class. So for something, you got a slow day, kill some time, and I think a lot of the classes you can kind of start, save, and pick up later, maybe.
I think ICS classes.
Yeah. So it's not like when you start it, you gotta finish the whole thing.
And you just need proof if we've done it recently?
Yep, so if you've got a 100, 700 certificate, you just bring that in, then you don't have to do it again. Or a WMD. But if you haven't done it, it's a statutory requirement. I'm not lying. If you've never been exposed to the incident command system, it's a very good thing that you go through. EMS, fire service, almost paramilitary in structure, with span of control and kind of who oversees what area of responsibility. It all fills within ICS. I mean, if you can imagine if we had larger incident, couple cars, crash, multiple patients, and everyone just kind of did their own thing and there was no coordination. It'd be a train wreck. So ICS helps us coordinate response and mitigation of these incidents. And really, everybody in the nation kind of falls within the same framework. So we can plug and play whether we're working with, Vilas County Sheriff's Department or Oneida County Sheriff's Department comes up to work, or maybe you're on Winchester Fire, but now you're working with Presque Isle. So, but they're all kind of falling within the same framework that we can all work together. But the train website is where we would get all those courses, and they're online, just kind of go through slide, and that's it. So I just wanted to show you that that's what the state site looks for. Your board, you want to poke around in there a little bit, there's a wealth of information that is in there. And I think it's 8:30, and I already shut off my PowerPoint. I think that's enough. So I think the next week, we will finish up the legal, ethical kind of discussion. I will for sure send you the first 3 chapter quizzes via email. Now remember, when I was looking at the quizzes, most of them are like 10, less than 20 questions. Take them, write them. We will go over the quizzes next week in class. So you can just, I like that you guys would use them as study material. Yeah, so if you're an ND license, we'll get everyone uploaded. Everybody has a textbook, correct? Okay. Any other questions, concerns about class before we clear you for the night? Okay, you will get more exciting, I promise. All right, thank you. We'll see you guys next week.